Hello, my name is Freda Kresh. I'm an emergency medicine attending. I love being out in the wilderness and practicing medicine out in the wilderness. And today I'm going to be talking to you about shoulder dislocations. So the shoulder joint is also known as the glenohumeral joint. A little bit of anatomy here. It's made up of the head of the humerus, which sits nicely inside of the glenoid fossa, unless there's a dislocation. And in that case, the head of the humerus shifts out of the fossa. It generally goes anteriorly or anteriorly and inferiorly, but occasionally it will go posteriorly in about 5% of cases. So how does this happen? So generally it happens from a blow to the arm in the abducted and externally rotated position. So high bracing and kayaking or other paddle sports when you have extreme abduction and external rotation. After a shoulder dislocation, the individual will generally be holding their arm away from the body and they're unable to bring the arm across the chest. So a telltale sign will be that they can't touch their hand to the opposite shoulder. The shoulder will appear square because of the anterior, medial, and inferior displacement of the humeral head. And there shouldn't be any crepitus unless there's an associated fracture. So going back to our anatomy, don't forget that the axillary nerve runs in this area and therefore you may have some compromise. When an individual sustains a dislocation, it's very important to do a good neurovascular exam, and you may find a lack of sensation in the lateral aspect of the upper arm in the mid-deltoid region, and that's because of some pressure on the axillary nerve. So if you're within, say, 30 to 60 minutes of a hospital or another facility, then you can wait. Otherwise, the patient will be a lot more comfortable if you actually do the dislocation, but only obviously if you know what you're doing. So in terms of reducing the dislocation, the most important thing is to remember that the humeral head wants to go back into its fossa, and it's really just the muscle tension and the patient's anxiety that is preventing it from doing so. So most important in every single reduction are the following three principles. Number one, relaxation of that muscle spasm, and you can do this possibly with some narcotics or benzodiazepines if you have them available. Number two is going to be reassurance of the patient, and last but not least is going to be the traction, and that's just to glide that humeral head over the anterior edge of the glenoid. So if available, you could start off with some pre-medication. Like we said, you can use narcotics or benzodiazepines, and those will help with the muscle spasm and pain. If you know what you're doing and you're able to do it sterilely, you could do an intra-articular joint injection, but obviously it's crucial that this be sterile because the last thing you want to do is introduce infection into the joint space. So let's start with some methods. So first of all, standing method, and this may be the only thing that you can do depending on the setting you're in. In this method, the patient is going to be standing up. They're going to bend over at the waist. The practitioner is going to support their chest with one hand and hold on at the wrist area with their other hand and apply slow, constant, steady downward traction and external rotation. If you have two practitioners, this may be a little bit easier because one person can support the chest while the other person applies the traction. The person who's supporting the chest can also help out by using their thumb to push at the inferior point of the scapula and push that scapula medially to help the glenoid fossa open up to allow the head of the humerus to slide back in. So in nature, you're going to want to use your resources, whether it's a bridge, whether it's a tree, whatever it may be. So in this case, you could see the patient is leaning over the edge of a bridge to apply support for him. And then the practitioner is using the method where he grabs on at the wrist and is applying that slow traction downwards. Another method that you've probably seen in a hospital setting that you can use in nature is the Stimson technique. And again, you're going to use whatever you have, whatever resources you have. So in this technique, the patient is going to lie on a flat surface. You may want to put something soft under the patient's shoulder so that they don't injure themselves. And then you're either going to apply a weight to their wrist or give them something heavy to hold inside their arm and just leave them there and let gravity do its work. So you want to use about a 4.5 to 9 kilogram or 10 to 20 pound weight. Another method you may want to use is traction, counter traction. So in this technique, you're going to go into your pack and you're going to find a strap or a rope or a sheet or a hammock or a jacket or anything of that sort. And you're going to actually need 2 of these objects because one of them is going to go around the patient's chest and one individual will be using an object to provide counter traction while the other individual wraps one of the straps or ropes or sheets or hammocks or jackets or any other piece of cloth around the patient's forearm and then around their waist and applies the actual traction. What's nice about this technique is that you can have free hands to manipulate the arm and help rotate it to bring the head of the humerus back into place. For individuals who dislocate frequently, you can use the shoulder auto-reduction method. This is generally intended for people who have dislocated many times throughout their lives and they dislocate easily and relocate easily. So here are the instructions that you're going to give to the individual in this method. So first of all, you're going to encourage them to relax because remember that is crucial in every single shoulder dislocation. You'll have them sit down on a hard surface and bend their knee to 90 degrees, and that's going to be the knee on the same side as the dislocation. They then need to clasp their fingers and hands around that knee, and very, 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 very slowly, over the course of 10 minutes, which may feel like an eternity in this circumstance, they need to lean backwards and drop their head back. It may help to push or shrug the shoulders forward and straighten the arms. All throughout, you want to encourage them to take deep breaths and try to relax. The procedure may feel weird, but it shouldn't be painful. If it's painful, you want to abort mission and try a different technique. After successful reduction, it's very important to sling the arm to ensure that it doesn't dislocate again. If you have a swath, it should be easy. Otherwise, you can always take their shirt and pin it to the clothing on their chest, and that should support the arm. So if in your circumstance the patient is going to need to ski or kayak or do some other sport to get back to a hospital or another facility, it's important to stabilize the shoulder. So if you have an elastic wrap, you can wrap it around the torso and the upper arm, and that will limit abduction and external rotation while they're getting back. As we said earlier, posterior shoulder dislocations are a lot more rare. They occur less than 5% of the time. They usually happen with a direct blow to the anterior shoulder or marked internal rotation, like with a grand mal seizure. You'll note that they have a lot less range of motion than one does when they have an anterior shoulder dislocation. And the reduction maneuver, aftercare, and indications for evacuation are the same as an anterior dislocation. If after 3 vigorous attempts you are unable to reduce that shoulder, at that point you should stop trying and you should arrange for evacuation. Here are some resources that I thought you might find helpful. If you have any questions, feel free to email me. Otherwise, best of luck with any shoulder dislocations or other wilderness emergencies.